Hello everyone, you are going to deal with regarding that pharmacokinetic models which will be under that physicochemical physiological models and as well as that distributed parameter models. Still now I have discussed about the different compartment models under the pharmacokinetic models that depending upon the model approach, whether it is the model independent approach, it will be classified into two types. That means first one is the model approach and second one is the model independent approach. That model independent approach is also said to be the non-compartmental analysis. Under that particular model dependent approach or the model approach, it will be classified into three types, that are that particular compartment model, physiological models and as well as the distributed parameter models. So far we have discussed about the compartment models in the previous classes, which will be having that, which will depending upon the some assumption that compartment models have been designed, and apart from that this compartment model simple, these are the empirical models, and this compartment model compartments will be divided on basis of that whether the perfusion, whether the drug, depending upon the drug input and as well as the drug affinity and blood flow, these compartment models will be divided, and different assumptions that made, or the that whole body is considered as it is having composed of number of compartment. That compartment will be either arranged in the series or in the parallel, and only thing here that each and every compartment will be well communicated reversibly with each other, and apart from that each compartment, whatever you are considering the group of tissues, it does not have any real physiological or anatomical reason, and apart from that within the each compartment the drug will be considered as rapidly and uniformly distributed, and apart from that rate of the drug movement between the compartment will be explained by the first order kinetics, and as well as the rate constant which is given by the k. The drug input and drug output is given by the k. And depending upon the arrangement, if that all the compartments are arranged in the parallel manner, that means like that whole that planets that connected to the satellite, like that if that particular arrangement is takes place, that compartment model is said to be the mammillary model. If the so far that compartments when arranged in the series like that joined each other, that compartment in the form of that compartments in the train, that is said to be the quaternary model. These are the different models: one compartment IV bolus, one compartment extravascular, two compartment intravenous, two compartment extravascular, three compartment. All these in the last class you have discussed. These are some advantages and as well as the disadvantages. Today we are going to deal with the physiological models. What are the physiological models? On what basis? Already we explained that compartment model, these are completely empirical models, and apart from that, the compartment is considered as assumed to have group of the tissue with respect to which are having similar blood flow and drug affinity towards the drug affinity. But here what will happen, these physiological models is models which are based upon the physiologically based on pharmacokinetic models. These are also called as PBPK model, that nothing but physiologically based pharmacokinetic models. And here that particular how many compartment that involved, here if you see simply depending upon the compartment that involved in the distribution, you can say this is one compartment, two compartment, like that. But how many compartment that involved in that particular model, pharmacokinetic model, can be given by, it can completely depending upon the disposition characteristics of that particular drug. Sometimes only the drug will be follows the absorption and then elimination. Sometimes it will undergo all the kinetic processes. The number of compartment that involved will be depending upon the disposition characteristics of that particular drug. And here that completely the whatever the model pharmacokinetic explanation, that quantitative estimation can be done on basis of that blood flow and blood perfusion only. That's why here the organs or the tissues which do not have any blood flow or which do not have any penetration will be excluded from here. That means only the tissues which is having the blood flow, which is having the penetration or perfusion rate will only considered under this particular physiologically based pharmacokinetic models. Based upon this concept, that means the blood flow there is for the bones, for some muscles somewhat, and nails, for the all these does not have any blood flow or perfusion rate or penetration will not be there. In such type of organs or the such type of the tissue tissues will be excluded from these models. Only that which are the tissues or the organs which are having some permeation and the blood flow only included. And apart from that, the tissues or the organs which are having perfusion rate, which are having the blood flow, will be divided into two types. Here there in the distribution already discussed, depending upon the blood flow, highly perfused tissue, moderately perfused tissue, poorly perfused tissue, you have divided. In the similar manner, depending upon the penetration or depending upon the perfusion rate, based upon the physiologically based pharmacokinetic model, their whole tissues and organs will be divided into two groups. First one is called RET and second one is called SCT. Nothing but are rapidly equilibrated tissues. The tissues such as liver, lungs, brain, kidney, all these tissues or the organs are having some more and more blood flow and more perfusion rate will be there. So all the tissues will be grouped under one type of the model, which are the one type of tissue, one group of tissues which are said to be the rapidly equilibrated tissues, while the muscles and the adipose which are having the somewhat poor moderate perfusion rate, moderate blood flow will be there. In such cases, such type of the tissues will be grouped under the tissue known as the set. They are nothing but slowly equilibrated tissues. And apart from that, and here the rate of the drug carried to the tissue or the organ or the tissue drug uptake is mainly depending upon the two factors. In the factors affecting distribution, already is said that in one of the important factor is blood flow to the organ. Greater the blood flow, greater the distribution. Greater the organ size, greater the distribution. Like that, some factors you are discussed under the chapter of the distribution. The same thing only discussed here. The rate of the drug carried to the organ or the tissue. Nothing but the rate of distribution of the drug to the particular organ or the tissue is mainly depending upon the two factors. First factor is rate of blood flow to the particular organ. Second factor is partition coefficient. That means whether that particular the drug, whatever after the absorption, the drug will be reaches the blood. Whether once the drug reaches the blood, the drug characteristic, whether it is having to partition with the tissue or the not. If the drug is not capable to partition with the tissue, the distribution will not be takes place. That means greater the partition coefficient, greater the distribution. That it is also said to be the diffusion coefficient of the drug that governs it the permeability. If that particular permeability factor will be more, to that permeation through that particular tissue cell membrane will be more, distribution will also be more. First thing is partition should be good and blood flow should be good, and as well as the distribution coefficient, diffusion coefficient. Once the drug is partitioned from the blood into the tissue, it should be diffused effectively in order to attain a optimum distribution. These are the two factors, very important factors to be considered, major factors to be considered in order to attain an optimum rate of drug carried to the tissue or the organ. In the similar manner, the physiological models further categorized into two types depending upon the blood flow or the perfusion rate. It can be explained under the two types. First one is the blood flow rate limited models, which or otherwise perfusion rate limited models. According to these models, what they are given an assumption means, based upon this assumption, the drug delivery will be more and more, where the in that particular organ, wherever the body region which is much more rapidly, wherever the perfusion of the blood will be more, in such cases the rate of drug delivery will be more. Only that is the assumption here. Basically, depending upon the physiological model, they are classified into two types. First one is the blood flow rate limited models and perfusion rate limited models. What is the assumption while making this model they have done means, within the body, whole body region, wherever that particular more and more perfusion blood will be region by where that perfusion blood will be more, in that area rate of drug delivery, rate of drug absorption will be more, they have mentioned. This is one of the important assumption. And this is the pharmacokinetic, physiological based pharmacokinetic model, or otherwise simply you can say physiological models. That means where Q, lung, these are the different organs which you are considering, tissues which you are considering, for determination of quantitative estimation of the different pharmacokinetic parameters. If you see, this is the venous blood. Through vein directly drug will be administered, from which the distribution of the drug will be takes place through the different tissues or otherwise the organ. If it is take place, we rapidly perfused tissue or rapidly equilibrated tissue or highly perfused tissue. This is the poorly perfused tissue or slowly equilibrated tissues. All the tissues which comes under the high perfusion rate, all the tissues which comes under the poor perfusion rate respectively, they are grouped under the HPT and as well as the PPT. And here these are the this is the lung, liver, gut and as well the heart, different tissues and organs have been mentioned here. The Q lung is nothing but, here the Q indicates blood flow to the respective organ or the tissue. If you are taking Q is nothing, Q lung is nothing but blood flow to the lungs, and QG is nothing but your blood flow to the gut wall. And here if you take, elimination will be takes place from, already you know it, elimination sometimes it takes place through the metabolism, which is the major organ. There the principal organ is the liver, and elimination or majority of the elimination is takes place through the renal route, there where the principal organ is the kidney. That elimination shows in the, here one elimination here and here, that will be governed by the rate constant, that is the Km, that is the rate constant. That elimination is takes place through the metabolism, and that particular blood flow through that liver is the QL they have given. And here that elimination, they are not mentioning here the K capital E. Why you are not mentioning here that overall elimination rate constant? That elimination rate constant only with respect to the renal excretion or the urinary excretion only indicated here. That's why KE indicates, that small e indicates that rate constant with respect to the urinary excretion rate constant. Simply you can say urinary excretion rate constant, where QK is nothing but blood flow to the kidney, and blood flow to the highly perfused tissue, blood flow to the poorly perfused tissue. Based upon all the considering all these organs are grouped under the highly perfused tissue and poorly perfused tissue, physiological models have been designed. And this is the development of one of the physiologically based pharmacokinetic model. And this is the schematic representation here, that what this model will be, that body is being comprised of simply similar to the compartments only. The whole thing, the whole body is comprises of the many organs and the tissues. Similar that each and every organ is will be considered as the one compartment, or otherwise second thing is, what are the organs which are having a similar disposition characteristic, similar perfusion rate, will be grouped under that particular one compartment. Each compartment is represents an organ or tissue group and linked to the central compartment. If you are taking, this is the central compartment, which there is having a much blood flow and the perfusion rate will be there. Here they are considering that it is having the group of tissues, and linked to the each and every tissue will be taken as the one of the which is having the high perfusion rate or the high blood flow is taking at the central blood compartment. And this connection is takes place by the arterial and as well as the venous blood flow. If that particular whole connection, here one organ, one tissue is connected through that particular arterial and as well as the blood flow, venous blood flow only. Here the model characterized by the physiologically based such as tissue volumes. What are the parameters you need to consider while designing physiologically based pharmacokinetic models? Mean these are the parameters you need to consider. Here is that parameters what you are considering here is, first one is that tissue volume and as well as the blood flow rates. What is the blood flow, what is the tissue volume, what is the tissue size in the distribution, or larger the organ size, larger the distribution, more and more the blood flow, more and more the drug distribution, more and more perfusion, more and more permeability of the drug reaches, drug delivery to that particular tissue or the organ will be more. Like that only, while designing this model, the sum of the parameters or or the factors you need to consider are, first one is the tissue volume and as well as the blood flow rates also. And apart from these physiological parameters, other parameters, biochemical parameters such as partition coefficient, whether the drug which reaches that blood venous blood, whether it is capable to partition with that particular tissue, whether it is lung or kidney or heart, whatever it may be, that particular group of the tissue, whether it is partitioned with that with respect to the drug or not. And apart from that, kinetic parameters for metabolism and as well as the excretion also you need to consider. These mainly, for what purpose these parameters or the factors you are considering will be useful means, in order to provide the mathematical description of the model using mass balance equation for the individual compound. Some equation, the protein binding P plus D is equal to PD. By applying the law of mass balance equation, it will be give Ka is equal to PD divided by P plus D. That means individual. Like that, whenever you are by using some mass balance equations for each and every individual compartment, you can estimate, you can give a simple mathematical description by using all these parameters. These parameters mainly useful for that purpose. This schematic diagram that indicates, what does it indicates means, first one is the CI. CI is nothing but concentration of the metabolite or concentration of the drug in a particular tissue with the time t. Tissue I, that particular whatever the tissue it may be, that that particular concentration of the genobiotic is nothing but metabolite rate to be considered, or otherwise the drug, that concentration of the drug in the tissue is given by the C. And here the Q is indicate, whatever the QI is indicates, whatever that QI indicates means blood flow rate through the artery, from the artery or through the vein, whatever it may be. Here that QI indicate the blood flow rate, and U indicates that particular U, whatever the V or the U, that indicate the tissue volume. Whatever the tissue you are considering here, first is the concentration in the particular tissue. Let it be considered that kidney only. That particular kidney tissue volume will be given by the term U. And as well as the A indicate concentration of the drug or the genobiotic in the arterial blood, and whereas the V indicate that concentration of the drug in that particular venous blood. And apart from that, Y indicates amount of the drug genobiotic that directly entering into the compartment indicate this. Y is indicate that the amount of the drug that entering into the central compartment or the entering into the compartment. Z indicate that amount of the drug that directly that goes away from, eliminated away from or removed away from the that particular compartment will be indicated by the Z. And here that simply you can say C is the concentration of the drug or the genobiotic in that given tissue volume, and Q indicate blood flow to the organ or from the organ to that particular organ, and Y indicate entering concentration of the drug, Z indicate that removing or the eliminating concentration of the drug. VI indicate concentration of the drug that entering into that venous blood. The way indicate that concentration of the drug in the arterial blood. Like that, different each and every parameter has to be considered here. This is one of the physiologically based pharmacokinetic model. And what are the advantages? Here you said that here the two types of the models have been there. First one is the blood flow rate limited and diffusion rate limited. What is the difference between the blood flow limited and as well as the diffusion rate limited? Here in the blood flow limited, the rapid drug equilibrium will be assumed that, and here there is no barrier, there is no, for the drug movement, cell membrane does not act as the barrier to the drug permeation. Whereas in the diffusion rate limited, what will happens here, the cell membrane is acts as the barrier. Once the drug will be get distributed in that particular blood uniformly, instantaneously the drug will be uniformly get dispersed into the blood. But here, in order to reach that particular tissue or the organ, the drug should be processed through the cell membrane. In the diffusion rate limited, the name itself it is saying that diffusion rate limiting or diffusion rate limited means that diffusion through that cell membrane to reach that particular organ organ or the respective tissue will be limited. That particular limiting will be takes place. That's why that cell membrane is acts as the barrier for the drug, which will be gradually permeates by the diffusion. We hear rapid diffusion of the drug and equilibrium will be takes place since barrier does not that cell membrane does not act as the barrier. But here at the cell membrane is acts as the barrier, it will be gradually permeation will be slow permeation, slow equilibrium will be takes place in the diffusion and limited model. And here, if no binding is takes place in the blood flow, there is no protein binding will be takes place because of that. When there is no macromolecular size, there is no high molecular size, what will happen? It will be easily passes through the cell membrane, so that the drug that reaches that venous blood, let it if the drug is administered through the intravenous route. In such cases, the entire drug that is administered or entire drug that will be reaches that venous blood will be equal to the concentration of the drug that reaches the tissue. If you are administering 250 mg, if no binding will be takes place in case of the blood flow rate limited, the same drug, entire drug will be reaches that particular tissue also. Whereas here what will happen in the diffusion rate limited, blood flow is very rapid and drug permeation is slow. In such cases, the drug concentration gradient is established between the tissue and the venous blood. That means somewhere the concentration in the venous blood, the difference, what is the concentration gradient? Nothing but the difference in the concentration of the drug on the either side of the membrane. Obviously, the difference in that venous blood and the tissue will also be takes place. But here, when no binding, entire drug without barriers, it will be enters into that particular tissue. Here, the rate limiting step is the blood flow. If the blood flow is stopped, in such cases the drug movement will be stopped and thereby there is no drug concentration in the tissue. Unless otherwise, if that particular blood flow will be stopped, that process will be optimally it will be done. But in the rate limiting step, permeation causes that particular rate limiting step. The name itself you are saying that diffusion rate limited or permeation rate limited. In such cases, rate limiting step is the permeation. Here, that particular when you are considering that blood flow to the blood flow limited model, in such cases, mathematical implement will be simplified. But here, what will happen? Time lag in the equilibrium between the blood and the tissue, the pharmacokinetic equation for the diffusion model is very complicated. If once that equilibrium, easily that equilibrium very rapidly attains, and apart from that, whole thing will be whatever the estimation, quantity estimation of the pharmacokinetic models can be done simplified by that whole mathematics. But here, why it will take much time to get equilibrium, because that particular perfusion, the time lag in the equilibrium between that blood and the tissue, the pharmacokinetic equation somewhat calculation will be complicated. And what are the advantages of this PPPK, that means physiologically based pharmacokinetic model, compared to the normal compartmental models, conventional compartment model? Here the mathematical treatment is very straightforward by considering that model so far explained here, by considering all the concentration, blood flow, what is the blood flow, concentration, entering concentration, exiting concentration, you can give the directly value estimation can be done. That's why the mathematical treatment is very straightforward. But in the compartment models, what you need to take, the sampling has to be done, and then the concentrations has to be taken, and after that data fitting has to be done by using the plasma concentration time profiles, and you need to take slope and substituting in that particular respective mathematical formulas, and everything will be there. But here the mathematical treatment is straightforward, and here since it is the realistic process, the model is suitable where the tissue drug concentration and binding is known. Since it is the realistic process, if the drug concentration, if the blood flow you know, what are the perfusion characteristics if you know, and the binding characteristics you know, it will be that particular, the model is suitable for that. Most of the cases this model is suitable if the drug concentration or the binding is known, since it is the realistic approach. And data fitting is not required. Here the mathematical treatment is straightforward. There data fitting. For that time interval, 5 minutes, this much of concentration, 10 minutes, some microgram per ml, that concentration. Data fitting has to be done. You need to take whether the linear curve, everything you need to consider. But here, data fitting is not required, since the drug concentration in the various body regions can be predicted on basis of the organ or the tissue size, perfusion size, and experimentally determined by the tissue to the plasma coefficient. You are not considering any concentration of the drug in the body, and that data so obtained, you are not plotted, interpolated in the plasma concentration time profile. But here simply that prediction is done on basis of the what is the organ or the tissue size, what is the blood flow, depending upon the blood flow or the perfusion rate, and apart from that, partition coefficient of the drug within the in between the tissue and the blood you are considering. Whereas there in the compartment model, data fitting you need to considering. And number of data points are less than that pharmacokinetic parameters to be assessed. And monitoring of the drug concentration in the body is difficult, and since the exhaustive data is required here. These are the disadvantages. Here, so far you are discussed about that particular advantages. Disadvantages, what is the disadvantage mean? Obtaining that experiment and considering these models in order to determine quantitative estimation of the PK parameters, this is very exhaustive process. And apart from that, most of the physiological model assume to have a average blood flow for the individual subjects, and hence the prediction of the individual dosing is difficult. Even though the organ, each and every individual will have the tissue grouped under the tissue, considering that organs are the tissue, that is the kidney, liver, everything will be considered. But that particular tissue size, blood flow, permeation characteristics will be differ from one individual to the another individual. In such cases, consideration of these physiological models for the quantitative estimation for the individual dosing is somewhat difficult. Why means that whatever the parameters you are considering, what are the biological parameters you are considering here means, first thing is organ size, organ flow, perfusion rate, all these are considered, but all these will be vary from one individual to the another individual. In such cases, the prediction of that particular estimation can be done by using the physiological models is somewhat complicated. And apart from that, the number of data points is less than the pharmacokinetic parameters to be assessed. Here in the compartment models, what is the data fitting is done for each and every time period, and according to the time period you can consider numerous number of the pharmacokinetic parameter. But here whatever the data points that whatever the results you are getting is less than the pharmacokinetic parameters. Very limited number of the data points you will get. It is not enough to estimate the maximum pharmacokinetic parameter. And monitoring of the drug concentration in the body is difficult, since exact data is required. Here less is not limited, limited data points are not limited. If we want the exhaustive data, majority of the data, in such cases monitoring of the drug concentration or the monitoring of each and every parameter is very, considering that biochemical parameters, biological parameters is somewhat difficult. And what is the basic difference between, so far you have discussed about the advantages and as well as the disadvantages of the PB PK parameters, and what are the advantages of that physiological models apart from that compartmental model. These are the differences between the compartment model and physiological model. First model is, this is completely, the compartment model is completely a hypothetical model, and apart from that it does not have any relation with the real physiological and the anatomical modeling. And here this is the realistic approach, completely based upon the physiological or anatomical information. Here that experiment is simple and flexible approach so far as the data collection is considered. Data fitting is very important. If the data collection is concerned, if you are considering, if you are concentrating on the data, it is okay. In such cases, this particular compartment modeling experiment is very simple and very flexible. With the particular time period, you have the particular data you will get, but difficult to experimentally, since exact data collection is required. With the limited points you can obtain, with that limited points is not enough to get the entire pharmacokinetic parameters. And here, owing owing to it that experimentally it is simple. Because of this experimentally simple, it is widely used and considering as the first model in it is the considering as a promising model in order to determine a various pk parameter. It is a less common owing to its complexity. Here exhaustive data is required and therefore it is a complicated process that is therefore it is less commonly useful. And here the calculation is it involves that multi-exponential mathematical treatment is required for the curve fitting method. In the first order, since whole compartment model assumed that it will be depends upon the first order context. If you say C is equal to C naught into e to the power of with that kt, and when it is converted into the exponential form, C is equal to C naught into e to the power of minus ket. Like that, some exponential component depending upon the number of compartments involved. If it the two compartment, it will be a bi-exponential. If it is a three compartment, it will be a tri-exponential. That's why it is said to be the as the number of compartments will be involved, the mathematical treatment multi-exponential treatment will also be complex. Whereas the mathematical treatment is straightforward. Simply by taking the blood flow, simply by taking the tissue volume, everything, you can directly substitute that values into the given formula. And here and next difference is data fitting is required for predicting the drug concentration in the particular compartment. As I said that the whole thing can be calculation, quantitative estimation can be done by using that plasma concentration time profile. With respect to the time interval, what is the concentration of the drug present at that particular time, particular compartment can be done by using the data fitting only. But here in the physiological model, data fitting will not be required since the drug concentration in the various tissue is practically determined. Here used when there is a little information about the tissue is enough. You are not considering the tissue volume, tissue blood flow, permeability characteristic, perfusion rate, nothing you are considering here. Little information is enough. Whether it's a highly perfused tissue or poorly perfused, that is enough. But here used when the tissue drug concentration binding or other biological parameters you know. And here easy to monitor the time course of the drug in the body with the limited data. But here the exhaustive process will be required to monitoring the time course of the drug in the body. And here exploitation from the data to human and the vice versa is possible. Whatever the data you are obtained from the particular animals, that animal data will be easily extrapolated into the human data, and same thing from the animals to human can be very easily. But here extrapolation of that animal data to human is easy on basis of the tissue concentration of the drug only. Here it is not possible, it is very possible. If you know that tissue size, tissue volume, in such cases that extrapolation of the data will be, and vice versa can be easy, but extrapolation is not possible in the compartmental modeling. And apart from that, the mechanism of the drugs ADME cannot be explained here. Here easy to explain that absorption, distribution, you are considering each and every realistic tissue, realistic organ you are considering here. Therefore that ADME mechanisms can be easily explained here. Effect of the pathological condition on drug ADME cannot be determined here. Here what will happen if that in the pathological condition, if some liver disease will be there, in such cases what will happen, the liver blood flow, liver permeation characteristics will be differ. By using that data you can, that effect of the pathological conditions on to that ADME can be easily determined. Here frequently used the data in the comparison of the various drugs, but less commonly used data in the in order to compare a drug, one data for the characteristics of the drug with the other drug, these compartment models are commonly frequently used. But in the comparison studies, these physiological models will be very less commonly used. And distributed parameter model. What is the distributed parameter model? Here this model is same analogous to the physiological model, but has been designed to account by considering there what you are considering that blood flow rate and perfusion rate limited only. Here variations in the blood flow to the organ and variations in the diffusion for each and every organ, some blood flow will be there. At the same time some permeation characteristics, diffusion characteristics will be there. If that blood flow variation will be takes place, what will happen? If the blood flow diffusion characteristics in the variation will be takes place to the particular organ, by assumption on these models have been designed. Such type of the models will be specially useful in assessing the regional differences of the drug concentration in the tumors or the necrotic tissue. In case of the cancers or the tumors, what will happen? The particular tissue or the particular skin part will be, the tissue will be get hardening because of the hypergrowth of that particular cells. In such cases the blood flow will be differ and the way that particular diffusion rate will be differ. In such condition, that assessing of that particular parameters in particular regional differences, this type of the distributed parameter model will be useful. Here only different is in the particular physiologically based pharmacokinetic models, it will be depending upon the blood flow and the perfusion rate. It will be designed on assumption variations in the blood flow to an organ and variations in the drug diffusion in the organ. This when it will be occurs means you mainly in the usually in assessing that regional differences in the drug concentration in the tumors and as well as the necrotic tissues. And next thing is non-compartmental analysis. Compartmental analysis is over and physiologically based pharmacokinetic model is over, and coming to the distributed parameter model is also over. Last one is non-compartmental analysis. This is the completely one chapter. This is only model independent method, does not considering any models, based upon the assumption that the drugs and the metabolites follow linear kinetics, and on basis of the technique can be applied any compartment model. Here what is the assumptions mean? Only the drug and the metabolites will be follows that linear kinetics, and apart from that the technique, whatever that linear kinetic what you are taking, that parameters will be applied to the any compartment model, whether the one compartment, two compartment, three compartment, irrespective of the number of compartments will be involved, that particular technique will be applied to the same type of the compartment. In the non-compartment analysis, this whole non-compartment analysis is based upon the statistical movement theory. It involves the collection of the experimental data followed by the single dose of the administration. Already here that particular important statistical distribution curve, the parameters you are considering is the MRT. MRT is nothing but that average amount of the time spent by the drug in the body before that is being eliminated. After once the drug is eliminated in the body, the drug will be spent some time in our body. The average time that spent by the drug in the body before removing away from the body, what is the time is given by the MRT, and it can be determined by that particular formula AUMC divided by AUC. Already you know what is the AUC. The total integrated area that covers under the plasma concentration time profile is said to be the AUC. AUC is nothing. AUC is determined by consideration the C. That means AUC 0 to infinity CDT. But AUMC is considering with respect to the C, it will be product of C and T it will be considered. Here MRT is determined by using the formula AUMC divided by AUC. MRT is the mean residence time, AUMC is the area under first movement curve, and AUC is area under zero movement curve or the area under the curve. This is the formula to determine the AUMC and as well as the AUC. AUMC is obtained by plotting a product of plasma concentration and time versus time, which will be takes place from 0 to infinity. It will be mathematically expressed by using this formula. AUMC is equal to 0 to infinity Ct dt, whereas AUC is obtained by plotting a curve plasma drug concentration versus time, which takes place from the 0 to infinity. Mathematically, AUC can be determined by using the formula AUC is equal to 0 to infinity integration of the 0 to infinity C dt. That means you are considering for the calculation only concentration terms, but here you are considering that both the term, that is concentration and as well as the time. This is the plot, its statistical distribution curve, which will be used that AUC and as well as which will explain that whole AUC and the AUMC. If you are taking here, in order to determine that AUMC, you are taking concentration and to time data. Here, in order to determine the AUC, you are taking that concentration versus time only, which will be, this is the practically AUC and AUMC can be calculated by using the trapezoidal rule. Thank you.